Okay, so welcome back to this next video in which we are discussing diabetes mellitus and anti-diabetic drugs. Okay, right. So we've just been discussing normal blood glucose homeostasis. Okay, now, whenever discussing normal blood glucose homeostasis, what you need to be doing is thinking about two different scenarios. Firstly, the fasting scenario, where you have not got glucose coming in via absorption by the intestine, and then the fed state, where you do have glucose coming in through the intestine. Now, we've just been discussing the fasting state, where you don't have to think about glucose coming in through the intestine. All you have to think about in that scenario is the fact that blood glucose is going to be leaving because it's being taken out of the blood by peripheral tissues such as the brain and used, okay, and therefore if we're going to maintain an equilibrium, something needs to be putting glucose back into the blood, and this is the liver. Okay, now, the liver puts glucose back into the blood through two processes, okay, namely gluconeogenesis, which is the production of glucose from certain amino acids known as glucogenic amino acids, okay, and also glycogenolysis, which is the breakdown of glycogen, which is stored within the hepatocytes, to glucose, okay, which can then be released from the hepatocytes into the bloodstream. Okay, right. Now, what tells the hepatocytes that they should be participating in gluconeogenesis and glycogenolysis to release glucose into the blood? Well, it's the two hormones, glucagon and insulin. Now, in a euglycemic state, which is the normal fasting blood glucose concentration, the alpha and beta cells of the islets of Langerhans will be releasing certain amounts of glucagon and insulin respectively. Okay, so the alpha cells are activated by euglycemia and therefore will be releasing lots of glucagon, which is the hormone that they release. Okay, the beta cells are not activated particularly that highly by a euglycemic state, and therefore they'll only be releasing a little bit of insulin. So in a euglycemic state, glucagon is high and insulin is low. Now, glucagon will then be acting on glucagon receptors on hepatocytes, and insulin will then be acting on insulin receptors on hepatocytes. Glucagon will trigger the activation of gluconeogenesis and glycogenolysis. Insulin will be activating the exact opposite. It will be activating a reduction in gluconeogenesis, so inactivating gluconeogenesis, and it will be activating glycogenesis, the buildup of glycogen from glucose monomers. Okay, so this little amount of insulin that's acting on the hepatocytes is acting to keep glucagon signaling in check. Okay, together the overall net effect of this signal and this signal is that this signal wins, that you do get gluconeogenesis and glycogenolysis, but this signal is taming the glucagon signal. Okay, and if you suddenly remove this signal, glucagon activates gluconeogenesis and glycogenolysis to its full extent, and that results in too much glucose being released from the hepatocytes into the blood, and that results in hyperglycaemia, and we'll see that later in diabetes. Now, just before we move on to the fed state then, what I want to discuss is two little things about the fasted state that I missed off. Okay, so this involves other tissues apart from just the liver. Okay, so the two other tissues that we need to talk about are the skeletal muscle, okay, which I'll put here, okay, which is a major part of your body, okay? A huge amount of your body mass is made up by skeletal muscle. So here's a piece of skeletal muscle. These are supposed to represent the tendons here. To make it look more realistic, I'll colour it in red here, the body of the skeletal muscle here. Okay, and the other tissue we're going to need is adipose tissue, fat. Okay, so I'll draw just a single adipocyte this time. So this is a single adipocyte, a cell within fat tissue. Okay, and within adipocytes, the most notable feature is that they have an absolutely massive, great store of lipid molecules. Okay, so this is an adipocyte here. Okay, right, and this is skeletal muscle. Okay, so Adipocytes and skeletal muscles cells do not have glucagon receptors on their surface. So glucagon is not going to be acting on these two tissues, but they do have insulin receptors on their surface. So insulin will be acting on these tissues. And when you have a very low level of insulin signaling occurring on these two tissues, certain things happen on these tissues. Firstly, the low insulin, okay, so this is insulin being low rather than glucagon being high. Low insulin causes the skeletal muscle cells to start breaking apart their proteins, which remember are polymers of amino acids, into amino acids, okay, a process known as proteolysis. So the low insulin is going to activate proteolysis in the skeletal muscle, okay, and you're going to be releasing amino acids into the blood. Okay, now what's the purpose of this? Well, these amino acids can then go to the hepatocytes in the liver and then be converted into glucose by the gluconeogenic pathways. Okay, so this is providing the amino acids that the liver needs in order for gluconeogenesis to occur. Okay, now let's talk about what low insulin is going to do to the adipocytes. Okay, well, low insulin is how you're going to recruit the fat stores that are within the adipocytes. After all, what is the purpose of the adipocytes? They are an energy storage, okay? We are currently in a fasting state. We do not have food coming in. Therefore, we need to harness our energy storages, and low insulin is going to be the signal for adipocytes to now start harvesting their stored lipids. Okay, so let me just explain what adipocytes have stored within them. So adipocytes have molecules known as triacyl glycerols stored within them, okay, or just triglycerides for short, okay, also sometimes abbreviated to TAGs for triacyl glycerols, tags. Okay, now these are exactly as the name says. They are a glycerol molecule with 3 acyl groups attached, which I'll illustrate here. So this molecule that I'm drawing in the great big lipid drop that's stored within the adipocyte here is supposed to represent a triacyl glycerol. That vertical line that I've coloured in green, and I think I'll draw this picture bigger, okay, because I don't think I'm going to be able to show it adequately at that size. Okay, so here is this molecule drawn out again. Okay, this vertical line that I've now coloured in green, that's supposed to represent the glycerol molecule. Okay, now glycerol has another name. It's also known as propane 1,2,3-trial, which I think I'll try and squeeze in down here. Propane 1,2,3-trial. And although propane 1,2,3-trial is a substantially bigger mouthful than glycerol, it's a more useful name because it tells us exactly what we're dealing with here. It tells us that we're dealing with a 3-carbon molecule, that's propane, where you've got alcohol groups coming off each of the carbons of that 3-carbon molecule. Okay, right, now what are you going to do to the glycerol molecule? Well, you're going to add 3 acyl groups onto it, which are these horizontal lines which I'm now showing in orange. Okay, each of these is a long chain carboxylic acid molecule that's been esterified onto one of the alcohol groups of this glycerol molecule, and you've put 3 different carboxylic acid molecules onto the 3 alcohol groups of the glycerol molecule, and hence created a triacyl, which is the name for that group of a carboxylic acid which you actually transfer on when you form an ester link. Glycerol, okay, because you've got 3 acyl groups attached to a glycerol molecule. Okay, so stored in adipocytes then you have the triacyl glycerols. Okay, now triacyl glycerols can be broken down to release the long chain carboxylic acids here, okay, and they're broken down by an enzyme known as hormone sensitive lipase. Okay, and hormone-sensitive lipase will chop the bond between the long-chain carboxylic acid and the glycerol molecule, and therefore release the free fatty acids, okay, which is another name for a long-chain carboxylic acid. So a fatty acid is another name for a long-chain carboxylic acid. So these molecules that I'm showing in orange here, these are fatty acids or long-chain carboxylic acids. Okay, so an enzyme called hormone-sensitive lipase can break this bond here and release the fatty acids from the triacyl glycerol molecules, and they are thence then called free fatty acids after that. Okay, now hormone-sensitive lipase is usually inhibited by insulin. Okay, so insulin acting on insulin receptors on the surface of the adipocytes causes the inactivation of hormone-sensitive lipase so that you don't then start breaking down triacylglycerols to release free fatty acids. When insulin is low, because we're in the fasting state, then this will stop. Okay, insulin will stop inhibiting hormone-sensitive lipase. Hormone-sensitive lipase will become active and it will break down triacylglycerols to release the free fatty acids, and the free fatty acids will then be released into the blood. Okay, now let's just talk about this a little bit more. Free fatty acids can't just be released into the blood because they are not particularly soluble. Okay, so what ends up happening is the free fatty acids bind to a protein in the blood, okay, known as albumin, a very famous protein present in the blood. Okay, and the albumin then transports them around the blood. Okay, now where are they going to go? Well, they're actually going to go to the hepatocytes as well. Okay, so free fatty acids will be delivered to the hepatocytes. Okay, and when they get to the hepatocytes, what do the hepatocytes do with them? Well, they use them to synthesize ketone bodies. That's a very important and well-known fact that you cannot, unfortunately, use free fatty acids to generate glucose. You can't use it in gluconeogenesis. You just can't make glucose from free fatty acids. The pathways for that just don't exist in humans. Okay, so instead what the hepatocytes do is they convert them into structures known as ketone bodies. So let me get another piece of paper and I'll discuss this. Okay, so the hepatocytes then are going to take these free fatty acid molecules, which I'll represent as these horizontal orange lines here, and I'll abbreviate it to FFA for short, for free fatty acid. Okay, and they're going to convert them into structures known as ketone bodies, and they're going to secrete these ketone bodies into the blood, and basically the ketone bodies can be taken up by peripheral tissues such as the brain and used for energy. Okay, so they can go to tissues such as the brain. The brain is the famous tissue which can use ketone bodies, and the brain can then metabolize the ketone bodies to produce ATP. So let me give you then examples of ketone bodies. Okay, so the two main examples, okay, of ketone bodies which the brain can use are acetoacetate and also beta-hydroxy butyrate. Okay, now I'm going to actually put these as their conjugate acid, okay, because that's going to be important later on when we come to discuss diabetic ketoacidosis. So acetoacetic acid, we'll call it. Okay, and let me show you the structure of acetoacetic acid, and then we'll move on to the other one. Okay, so acetoacetic acid then, its structure is that it's going to be acetic acid. Now, acetic acid is another name for ethanoic acid. It's the old name for ethanoic acid. And ethanoic acid is a 2-carbon carboxylic acid. Okay, so this is the acetic acid portion here. Now, the aceto then means that we're going to have another one of these molecules effectively linked on here. So let me show you how this is going to work. Here is the carbonyl group of this other acetic acid molecule, and then you've got the methyl group here. Okay, right. So this group that you've got attached onto the acetic acid here, this is an aceto group, and hopefully you can see how it's similar to an acetic acid molecule. In fact, if instead of this we had an alcohol group attached there, that would be an acetic acid molecule. So that's the aceto group. Okay, and then it's attached to an acetic acid molecule, so it's called acetoacetic acid. Okay, so this is the form where you've still got the proton actually attached to this oxygen here. Often the proton will dissociate from this oxygen here. When the liver makes this and spits it out into the blood, the proton does dissociate from this, and it becomes acetoacetate, okay, which is this exact same molecule but without the proton attached onto that oxygen. So that oxygen would just have a negative charge in acetoacetate. So acetoacetate is the conjugate base of acetoacetic acid. Okay, and that's an important point, that this is an acid molecule capable of donating protons away into free solution, and when you tip it into the blood, it will dissociate from its proton, it will become acetoacetate, and it will donate that proton into the blood, which means you are adding protons into the blood, which means you're making the blood more acidic whenever you put these in. Okay, and if you put too many of these in, it can cause major problems, and we'll talk about that later on in diabetic ketoacidosis. Okay, so that's the first ketone body, which can be sent to the brain as an energy source. The other ketone body is hydroxybutyrate. Okay, and this has a very, very similar structure to acetoacetate. In fact, it's just the reduced form of acetoacetic acid here. Okay, again, I've written out the conjugate base. The original acidic molecule would be beta-hydroxybutyric acid. So I think I'll show you the structure of beta-hydroxybutyric acid before I show you the structure of beta-hydroxybutyrate. Okay, so beta-hydroxybutyric acid then. Butyric acid is another name for butanoic acid, okay, a 4-carbon carboxylic acid molecule. So let's draw this here. So here's the carboxylic acid group, and now we need an additional 3 carbons to take us up to 4 carbons. Now, how do you label up the carbons within a butanoic acid molecule? Well, nowadays what we'd do is we'd call this carbon number 1, this carbon number 2, this carbon number 3, and this carbon number 4. However, that's not the way they used to do it. The way they used to do it was to call the first carbon off the carboxylic acid carbon the alpha carbon, to call the second carbon that comes off that the beta carbon. Okay, so this would be the alpha carbon, this would be the beta carbon, and then the final one would be the gamma carbon. Okay, so that's what this beta here means. It means that the hydroxy, and I'm going to colour it in a different colour. Okay, this beta means that the hydroxy is going to come off this beta carbon here. Okay, so let's add that on. Here's an alcohol group coming off the beta carbon here, and you also have a hydrogen, and then that's it, beta-hydroxybutyric acid. We don't need anything else. All we need to do is now just put all the other bonds as hydrogens coming off these carbons, like so. Okay, so that's the structure of beta-hydroxybutyric acid, and you will hopefully see how similar that is to acetoacetic acid. If this was to be oxidized, okay, if this alcohol group was to be oxidized, it would form a ketone group like that. Okay, so these two are very much so related. Okay, right. Now again, the proton of this alcohol group of the carboxylic acid group can dissociate, and when it does, that will go off into solution, and the molecule that you will have left over will contain an oxygen here with a negative charge, and that is what is meant by beta-hydroxybutyrate. So when the liver produces beta-hydroxybutyric acid and chucks it into the blood, it will then dissociate from its proton to become beta-hydroxybutyrate, and that proton will go into the solution of the blood, again contributing to the acidity of the blood. Okay, and again that will be a problem later on. So these are the main 2 ketone bodies which can actually be used by the brain for energy sources. Okay, right. So, to summarize then, in the fasting state, when insulin levels are very low, what will be happening is the adipocytes will start to break down their triacylglycerols to release free fatty acids, which will go into the blood, and then those free fatty acids will be delivered to hepatocytes, and the hepatocytes are going to use them to make ketone bodies, which they are then going to chuck into the blood for the brain to use as an energy source. Okay, so it's another energy source for the brain. Okay, so that's the fasting state. Now this isn't truly part of glucose homeostasis, but this is an important thing to understand to get the full picture of what is happening in the fasting state of metabolism. Okay, and it's going to be important later on when we come to discuss some of the acute complications of diabetes. Okay, right, so now what we want to go on to is looking at what happens instead when you are in the fed state. So when you have just eaten and you've got lots of carbohydrate in your gastrointestinal tract, and glucose is therefore coming into your bloodstream from your gastrointestinal tract. So let's draw a picture here. So we're now going to do the fed state, and we're going to see how does the body try to maintain a constant blood glucose concentration in the face of a huge amount of glucose being delivered from the intestine. Okay, right, so let's just draw a picture of the gastrointestinal tract so that I've got something to point at. So here's the esophagus, here is the stomach, okay, the pylorus, okay, and then we'll just draw the small intestine, or at least a bit of it. Okay, so here's the duodenum coming here. Okay, in fact, actually, we're going to need, when we discuss the incretins in a moment, to know about the different portions of the small intestine, so that we might as well discuss the anatomy of this now. Okay, so the small intestine is divided up into 3 different portions. Okay, so let me start pointing at these. So, this first portion, which is just where the stomach has now ended, okay, with the pyloric sphincter, the portion that I'm now colouring in orange, that portion there, this is known as the duodenum. Okay, this is the first portion of the small intestine. Okay, the portion after the duodenum, which is all the rest of the small intestine that I have got round to drawing so far, all of this portion in red here, this is then the jejunum. Okay, so this is the jejunum. Okay, after the jejunum, you then have the next portion of the small intestine, which is the ileum. Okay, so all of this is the ileum. Okay, and we actually are going to need to know the colon as well, so I'll just put the colon on here, which is the large intestine, so that isn't part of the small intestine, but I'll just label up this final portion of the small intestine firstly. So duodenum, jejunum, and ileum, they are all the small intestine. Then the large intestine begins with the cecum here. Okay, and then you've got the large intestine. I suppose I should make it look larger than the small intestine. Okay, so it's going to come up like this, okay, right up here, and then it's going to come out, and how am I going to show this? Oh, it's going to make a mess. Okay, maybe I'll just leave it at that for the large intestine, okay, otherwise we're going to end up drawing it all across here. Okay, so this can represent the colon. This is the ascending colon anyway. It will then go out in front here, that will be the transverse colon. Down here, that will be the descending colon, and then you'll have the sigmoid colon, and then into the rectum. Okay, right, so I'll colour in the colon here in turquoise. Okay, and that's the large intestine, and this little bulb of it here is the cecum. Okay, right, so we have currently got loads of glucose then coming into the bloodstream from the intestine because we've just eaten. Okay, so you're getting loads of glucose coming into the blood. Now, what's the effect of this? Blood glucose is no longer euglycemic. Okay, instead blood glucose is going to go up, up, and away. Okay, so what effect is this going to have on insulin and glucagon? So we need to go back to the pancreas. Okay, so I'll draw my pancreas here, like so. Okay, and then we've got an islet of Langerhans here, and I'll just draw 2 cells in it, just because otherwise we won't be able to see them if I actually draw them to scale. Okay, so we've got our alpha cell here in blue, supposedly, but it's smudged so bad you can't really tell, and then the beta cell here in green. Was that the colour codes I used previously? It might have been, yes, that was the colour code I used previously. So here is alpha in blue and beta in green, and I'll just underline them so that it's very clear. Beta's in green, alpha's in blue. Now, blood glucose then is going through the roof because you've got so much glucose coming in from the intestine. Okay, what effect does this have on the alpha cells and the beta cells? Well, the effect on the alpha cells is going to be complete shutdown. The alpha cells are going to stop releasing glucagon at any sort of large amount. Okay, so glucagon release is going to go totally down. Okay, so glucagon now goes down. Okay, what's the effect on insulin release then? The beta cells, those get activated by the increasing glucose concentration in the blood. Okay, so insulin secretion is now going to go hugely up. Okay, so we've completely turned it around. Before we had high glucagon, low insulin. Now we've got it completely the opposite. Glucagon has gone down because the alpha cells are sensed high glucose in the blood, okay, and insulin has gone up because the beta cells sensed high glucose in the blood. Okay, so it's completely twisted in the opposite direction. Okay, now, what then is the effect of insulin going up and glucagon going down? Okay, well, we'll start with insulin going up and then we'll come on to glucagon going down. Okay, because glucagon, remember, is only going to work on one organ, really. It's only going to work on the liver. Okay, insulin is going to work on 3 different tissues. It's going to work on skeletal muscle, it's going to work on liver, and also adipocytes. Okay, so we're going to begin with insulin. Okay, now, the most important target for insulin in this sort of situation is actually the skeletal muscle. Okay, most people would guess the liver because the liver is incredibly important, but skeletal muscle is the major target of insulin. Remember how much skeletal muscle you have, how much bigger the total mass of skeletal muscle is than the total mass of liver, at least in most people. Okay, so we'll start with insulin's effects on the skeletal muscle then. So where should I show this? So it's a shame I don't really have enough room on this picture. I'll try and put it here. Okay, I might draw a brief picture here and then go into more details on the other side of this piece of paper. Okay, so we'll put the skeletal muscle then here. So I'll try and draw a piece of skeletal muscle again. So here's the belly of the muscle, and then here is a tendon, and here's another tendon here. Okay, so once again I'll colour it in red to make it look more convincing. Okay, right, so insulin now is going to affect the skeletal muscle. Now what's it going to do then? It's going to make the skeletal muscle start to uptake a huge amount of glucose out of the blood. Okay, so high insulin is going to work on insulin receptors on the skeletal muscle here. So I'll just label this up. This is skeletal muscle. Whoops. Skeletal muscle. Okay, and it wasn't a good idea to draw over the top of that picture, but never mind. Okay, and the things that it does is it starts to make the skeletal muscle cells take up glucose. Okay, so glucose uptake goes up. And this is one of the places where I'm going to go on to the other side of the piece of paper and discuss in more detail how does it make glucose uptake go up. Okay, so let's draw our skeletal muscle cell here. Okay, so this is our very long skeletal muscle fibre here. Then we'll put our insulin receptor up here, which remember consists of these 2 beta chains and the 2 alpha chains, like so. Now what will happen is a single insulin molecule will come and bind between the 2 alpha chains there. So I'll colour this in. So here in green, those are the 2 alpha chains. And in orange here we have the 2 beta chains. Okay, then what will happen is this insulin receptor will set up all sorts of cascades, very, very complicated and still not completely understood. And what this will lead to is it will lead to certain vesicles fusing with the plasma membrane. Okay, so there's a vesicle here. Now what does this vesicle contain? Let me draw it out in more detail. This vesicle actually contains lots of proteins implanted into it, in its membrane, okay? Like so. Now what are these proteins? Well, they are proteins known as GLUT4 proteins. Okay, now this stands for glucose, that's the glue, okay? And then the T is for transporter. So this is the glucose transporter 4. Now, it is a facilitated transporter of glucose, okay? So what that means is it does not use energy, okay? It doesn't, it's not an active transporter. It does not need to couple the movement of glucose to ATP hydrolysis or some other chemical reaction which releases energy, and neither does it need to couple it to the movement of something else down its electrochemical gradient. Basically, what's going to happen is you're going to insert these GLUT4 transporters into the plasma membrane by fusing this vesicle with the plasma membrane. So when you fuse the vesicle with the plasma membrane, the membrane of the vesicle becomes part of the cell membrane, and now you're going to end up with lots of these GLUT4 transporters all over the cell membrane. Now, when blood glucose level is through the roof, because you've got loads of glucose coming in from the intestine, then glucose concentration will be higher in the extracellular fluid than it is within the cytoplasm of the skeletal muscle cells. Okay, so it will be, if the GLUT4 transporters move glucose into the cell, that will be down glucose's electrochemical gradient. Okay, so that's why these transporters can move glucose into the cell without requiring any energy, because they're moving glucose down its electrochemical gradient, so it's releasing energy by moving glucose into the cell. Okay, so that's why you can move glucose into the cell without requiring any energy, because you're taking advantage of the fact that blood glucose is so high at the moment, and therefore glucose electrochemical gradient will favour the movement of glucose into the cell anyway. Okay, so the insertion then of GLUT4 proteins into the cell membrane of the skeletal muscle cells is going to mean that you're bringing in more glucose into the cytoplasm of these skeletal muscle cells. Okay, so I'll represent glucose as my hexagon here. Okay, and I might even colour it in. I'll colour it in turquoise here. So this is glucose in turquoise here. Okay, right, now you're not just going to increase glucose uptake into the skeletal muscle cells, you're also going to actually do something with this glucose. Okay, you're going to build it up into glycogen. Okay, so the insulin receptor is also going to activate glycogenesis, just as it does within the liver cells, okay, which we've already discussed. Okay, so now what's going to happen is the skeletal muscle cells are also going to start assembling the glucose into glycogen, and it's the insulin receptor that activates this chemical process. Okay, so here is a little drawing of some glycogen being assembled here. Okay, so I'll colour those glucose monomers in again. Okay, like so. So you're going to build glycogen, and that process is known as glycogenesis. So basically what's happening is the skeletal muscle cells are going to take advantage of the fact that blood glucose is so high at the moment to build up their reserves of glycogen. Okay, now why do skeletal muscle cells need reserves of glycogen? Well, when they actually are being used, when you're doing some exercise, this glycogen is going to be broken down to release glucose monomers, which are then going to be metabolized by the skeletal muscle cells. Okay, so it's important to understand that skeletal muscle cells are not like liver cells. Okay, they are making this glycogen for purely selfish reasons. They are going to use it for themselves. They are not going to cut this up and release it back into the blood for other cells to use. That's the job of the liver. Skeletal muscle cells are just making glycogen for themselves. Okay, we'll come on to the liver making glycogen later on. Okay, right. Now the other thing that I should say is also when insulin is high, you're going to have the inactivation of proteolysis. Okay, so remember in the fasting state, because of the low insulin, you've got activation of proteolysis, okay, to release amino acids into the blood, which could then be used by the liver in the gluconeogenesis pathways. Okay, when insulin is high, you have a full break on proteolysis. You do not need it. Okay, you've got loads of glucose. Why on earth would you want to break down the proteins of the skeletal muscle cells so that you can send amino acids to the liver to make more glucose? No, of course not. So you completely stop proteolysis, basically. So proteolysis is going to go down. Okay, so those are the three effects of insulin on the skeletal muscle cells. They increase glucose uptake, and I should have a little arrow there saying it's going to go up. Okay, they increase glycogenesis, because obviously if you take loads of glucose, you have to actually do something with it. Okay, and they stop the proteolysis, so that because we don't need amino acids being released into the blood for gluconeogenesis by the liver when we've got loads of glucose coming in from the intestine anyway. Okay, so that's the effect of insulin on the skeletal muscle, and that is the primary target of insulin. This is why you can control glucose when you eat, okay, because it's all going to go into your skeletal muscle cells. Most of it is anyway. Okay, the other two things that happen, those are on the side of this, basically. This is the main way that you stop blood glucose going to dangerous levels. Okay, right. Now let's talk about the next thing. Let's talk about the liver now, and then we'll finally move on to the adipocytes. Okay, so liver next. We'll put the liver up here then. Okay, now the liver is going to feel both the rise in insulin levels and also the drop in glucagon levels. So you're getting a double signal going to the liver, not just the rise in insulin, but the drop in glucagon. Okay, the skeletal muscle cells, they don't listen to the glucagon whatsoever, they just listen to the insulin. Okay, so what's the effect then in the liver of insulin going up and glucagon going down? Okay, well, insulin is going to trigger the liver to stop using gluconeogenesis. Okay, so now gluconeogenesis is going to go down. Okay, and that's not just because the insulin is inhibiting gluconeogenesis, it's also because now the glucagon is not activating gluconeogenesis. So for both of those reasons, you're going to stop gluconeogenesis. You could also argue that the lack of the amino acids that you actually need for gluconeogenesis is also going to help stop gluconeogenesis. Okay, so gluconeogenesis is going to go down to very low levels. Okay, so you're not anymore spitting a significant amount of glucose into the blood because you're making it from amino acids. Okay, so that's one of the effects. In addition, we're going to start taking glucose out of the blood rather than putting it back in. Okay, and we're going to start making the glucose up into glycogen molecules, just like the skeletal muscle cells. Okay, so we're now going to build back up our stores of glycogen. Okay, so remember, in the fasting states, we need to harvest these stores of glycogen within the liver. So in the fed states, we have to replenish them back up. And when you've got very high blood glucose, glucose isn't going to now be leaving the hepatocytes. Instead, it's going to be coming into the hepatocytes simply because of its electrochemical gradients. Okay, then that glucose is going to be used to build glycogen. Okay, so you're going to be making glycogen through glycogenesis. Okay, right, so those are the two major effects that you have on the liver, and those are both because of glucagon being down and insulin being high. So obviously glucagon being low rather, is going to stop the glycogenolysis process, okay, because glucagon drives the breakdown of glycogen into the glucose monomers. So if it's low, then you're going to stop breaking down glycogen into the glucose monomers. Okay, right. So that's the effect on the liver. Now what we want to turn our attention to is the effect on the adipocytes. Okay, so I'll draw an adipocyte here. Okay, so once again, this is this large storage of triacylglycerols in the cytoplasm of the adipocyte, and here's its little nucleus pushed to one side up here. Okay, so this is an adipocyte. Okay, and I think I'll colour in the adipocyte in yellow. Okay, so what's the effect of having high insulin on the adipocytes? So the adipocytes are like the skeletal muscle cells. They respond to the increase in insulin rather than the drop in glucagon, so they only listen to this. Okay, they have an insulin receptor on their surface, and the insulin receptor firstly does the same thing as it does in skeletal muscle cells. It causes the translocation of these vesicles containing GLUT4 from the cytoplasm to the membrane. Okay, so that you end up with GLUT4 transporters in the membrane of the adipocytes. Okay, which I'll show here. And this is going to result in an increase in glucose uptake by these adipocytes. Okay, so glucose uptake is going to go up, basically. Okay, now in addition, what the insulin will do is it will block the hormone-sensitive lipase enzyme, which I'll abbreviate down to HSL. Okay, so hormone-sensitive lipase will now be inactivated, okay, and that will mean that we're no longer breaking down triacylglycerols into free fatty acids and releasing those free fatty acids into the blood. So free fatty acids in the blood are going to go down, and that means that the liver is no longer going to be making ketone bodies, so ketone bodies are going to go down. Okay, what are the adipocytes actually going to do with the increased glucose they're getting? Well, what else are they going to do? They're going to turn it into fat molecules, basically. So, here's a fact for you. You cannot turn fat molecules back into glucose. That's what we said earlier. That's why you have to turn them into ketone bodies instead. Okay, but you can turn glucose molecules into fat molecules, and that's what these adipocytes are going to be doing. They're going to be taking up the glucose from the blood, converting it into fat molecules, and storing them in their lipid lipid droplets here. Okay, so that's why even if you eliminate fat from your diet, you can still gain fat cells. Okay, you can still gain adipose tissue because carbohydrates can be converted into fat stores by the body. Okay, right, so here is our triacylglycerol molecule in that fat droplet within the adipocyte there. Okay, so again this is going to be contributing to the removal of glucose from the blood and also the building up of energy stores which can be harnessed by the body later on when needed. Okay, right. So that now concludes our discussion of normal glucose homeostasis. All that I have to say is one last little thing that is going to be important when we actually discuss drugs, and therefore I'm going to mention now. It is part of the normal physiology by which this occurs, but it doesn't seem as important as what we've discussed so far. Okay, but it becomes very important because many of the drugs that we're going to talk about later actually work by intervening with this little system that sits on the side. Okay, so basically what I now want to mention are things known as incretins. Okay, now incretins are going to be released by the intestine in response to the presence of carbohydrate within the intestine. Okay, so let me tell you about the two major incretins. So the two major incretins that we're going to talk about are firstly GIP, okay, which stands for glucose dependent, okay, that's the G, okay, then glucose dependent insulinotropic polypeptide, so the I is for insulinotropic, okay, and then P is polypeptide. Okay, so what this name implies is that it's going to somehow boost the insulin signal, insulinotropic, growing the insulin signal in a glucose-dependent manner. So glucose-dependent insulinotropic polypeptide. So the G is for glucose-dependent, I for insulinotropic, P for polypeptide. So that's one of the incretins. Okay, the next one then is another incretin, and it's known as GLP-1. Whoops, let me just rewrite that out. GLP-1. Now GLP-1 stands for glucagon-like peptide 1. Okay, right, so let me explain what the incretins are going to do then. Basically, both of these molecules are going to be secreted by the intestine, different portions of the intestine, which is why I wanted to talk about the anatomy of the intestine earlier on. Okay, and they're going to have effects on the amount of insulin secreted by the beta cells of the islets of Langerhans in response to a certain rise in glucose. Okay, so firstly, let me tell you where they're going to be secreted by. Okay, so basically, GIP, glucose-dependent insulinotropic polypeptide, is going to be secreted by the early portions of the intestine. Okay, so the duodenum and the jejunum. Okay, so in orange and red, these two portions are going to be secreting GIP, so I'll put this on here. So GIP is going to come from these two portions, and the other incretin, the GLP-1, okay, glucagon-like peptide 1, that's going to be coming from the later portions of the intestine, such as the ileum and also the colon. Okay, now, what both of these molecules are going to do is they're going to have what's known as the incretin effect, okay, on beta cells of the islets of Langerhans. Basically, when these two hormones are high within the blood, and glucose is high within the blood, the amount of insulin you get released is bigger than when glucose is just high on its own. So let me put this, make this plainly clear. If you were to take glucose and inject it into the blood, okay, and you were to raise blood glucose to a certain level, okay, the beta cells would secrete a certain amount of insulin. Okay, if you were to raise blood glucose to that exact same level via oral delivery of glucose, so you give the glucose orally, then the amount of insulin you get released by the beta cells is bigger. Okay, that's known as the incretin effect. And the reason for it is that if you give the glucose orally via the intestine, okay, then the glucose will trigger the release of these incretins, glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1, which will act on the beta cells. Okay, and they don't cause the release of insulin themselves, but when glucose goes up in the blood and triggers the beta cells to release insulin, the amount of insulin that will be released by those beta cells in response to that rising glucose will be bigger if they've also been acted upon by one of these incretins. So the incretins boost the amount of insulin released in response to a certain rise in glucose. They potentiate the release of insulin, basically. Okay, so these two boost the amount of insulin released in response to a certain glucose concentration within the blood. Okay, right, that's their major effect. Now they also have another effect, which is on the stomach. Okay, they also delay gastric emptying. Okay, so they delay the moving of the food bolus from the stomach into the intestine. Okay, so remember, at the bottom of the at the bottom of the stomach here, you have a sphincter known as the pyloric sphincter. Okay, and this controls the movement of food boluses from the stomach into the intestine. Okay, so if you've got food in the intestine already, you don't want food to be coming from the stomach into the intestine. Okay, so the presence of carbohydrates in the intestine triggers the release of these incretins from the intestine. I should have said that actually. It's the presence of carbohydrates in the intestine that causes the intestine to release these two. Okay, not just the presence of any old food, it has to be carbohydrate. Okay, then you don't really want more food to be coming in yet. Okay, so they delay the emptying of the stomach, they delay the opening of the pylorus, basically. Okay, now why is that an advantage? Well, firstly, that causes an increased satiety signal to go to the brain, because food being present in the stomach is what makes you feel full. Okay, so firstly, delaying gastric emptying produces satiety, and also it means that you're not going to get too much carbohydrate coming in here and raising blood glucose even further, because if you bring more food in here, then that's going to bring more glucose into the intestine at the same time as this glucose is already coming in. Okay, so the spike in glucose that you'd get due to eating the meal would be bigger. Okay, and there's a fancy piece of terminology here that I mentioned earlier, okay, but which I'm going to use a lot now, which is the postprandial glucose spike. So when you eat, your blood glucose temporarily goes up. Okay, this is known as a postprandial glucose spike, or just a postprandial spike. Postprandial means after eating. Okay, so prandial refers to eating, post refers to after. Okay, so after eating, glucose spike. Right, so these incretins then, not only do they increase the amount of insulin released in response to a certain rise in blood glucose, but they also delay gastric emptying whilst there is carbohydrate still in the intestine. The effect of that is firstly to induce satiety, to make you stop eating, and also that it stops too much food coming in here. And if you have more food in here at this one time, then you'd be releasing more glucose into the blood at that single time point, and therefore the spike that you get would be bigger. Okay, it's best to leave this food till later, have it later, and have a more prolonged postprandial glucose spike than have a really sharp postprandial glucose spike. Okay, right. The last thing then that I want to just say about the incretins, because again it will be important when we come on to the anti-diabetic drugs, is that they are broken down by an enzyme which is present in the blood. And the enzyme present in the blood which breaks down incretins is known as dipeptidyl peptidase 4. Okay, and for short, dipeptidyl peptidase 4 is often abbreviated to DPP4. Okay, D for di, P for peptidyl, P for peptidase, and then 4. So dipeptidyl peptidase 4 is an enzyme present within the blood which will break down the incretins GIP and GLP-1 and hence prevent them from having their effect for too long. Okay, right, and these molecules, these enzymes, these proteins, GIP and GLP-1 and DPP-4 are going to be important drug targets when we come on to anti-diabetic drugs. Okay, right, so we'll call it there for this video. We have now finished glucose homeostasis, and what I'm going to move on to in the next video is discussing the different types of diabetes mellitus.